So for every individual out there who may be thinking about fertility, just speak up. Like whatever we can do, ask questions, be heard. You're important, and we want to take everything into consideration.
Hello there, I'm Sally McNally. I'm the Irish midwife. Welcome back to the Bleedin Truth podcast. And today I'm very excited. I'm a big fan of this wise lady I'm going to introduce you to today. Her name is Dr. Amy Dhesi, and she's a highly regarded reproductive endocrinologist and infertility specialist, brings over a decade of expertise in reproductive medicine to Fertility and Surgical Associates of California. She earned her medical degree from University of California, San Francisco, completed obstetrics and gynecology residency at University of California, Los Angeles, and a fellowship in reproductive endocrinology and infertility at Rutgers University. What a mouthful. Dr. Dhesi's impressive professional journey includes serving as a partner physician at Kaiser Permanente, where she honed her skills in patient care and advanced reproductive techniques. Additionally, she has several years of experience working at various Southern California fertility practices, which has allowed her to further develop her skills as a fertility specialist treating complex fertility issues. Dr. Dhesi has also been awarded the Castle Conley Top Doctor Award for 2025. Congratulations, how wonderful.
Thank you. I'm so
Welcome.
excited to be here.
Thank you for giving us this time to help us to understand what your work is and who you help. Um, and I would like you to maybe tell us a little bit more about yourself, Amy.
Sure, sure. So, as the Sally's already said, I am a reproductive endocrinology and infertility physician. I've been in practice for about 10 years now. It's been fabulous. Quite a long journey, but a wonderful journey nonetheless. It's an area that I hold true to my heart. It's an area that I've been so passionate about, and love how new of a field this is. It's constantly developing,
Yeah,
which is amazing. Like constantly getting knowledge of scientific literature, ways that we can help individuals. But it's an amazing specialty, and I'm so proud to be a part of it.
great. Yeah, so great. And so, what inspired you? I mean, you were moving into obstetrics and gynecology, and somehow infertility was the calling.
Yes. So I guess, it really stems back from the science aspect of it. I loved learning about the reproductive system, the hormones that were at
Yeah.
play, all the things that work in our body, and when they don't work, what happens, and what can be done, and how do we fix things. I loved being able to problem solve. And so that's what sparked my interest initially. And
Mhm.
then I loved being able to take it clinically to patients, to people who are struggling to build their families. We get to work with a wide variety of individuals out there. We have our heterosexual couples, we have our LGBTQ plus individuals and couples, we have our single parents, we have people with like complex medical histories who are now having to make decisions about fertility, more emergently. And it's such a breadth of individuals that we get to work with, and really
So
helping them
great.
build their families
Yes.
is so rewarding.
It's so great. We have patients coming back to our office in Ventura who've been to you and they're pregnant and they're so excited and so happy. And without the gifts that you have to give them, their life would be so different. So how would you define infertility? What is
Or
infertility?
So the traditional definition is no pregnancy after regular unprotected intercourse for at least 12 months in women under 35 years of age, and at least 6 months in women who are 35 years of age and older.
Okay.
But that's not the only definition. There are other definitions of infertility. So, for example, the inability to achieve a successful pregnancy based on one's medical history or their sexual history, reproductive history, or age, physical exam findings, or testing that they've had done. So, it doesn't always have to include a year of unprotected sex or 6 months of unprotected sex.
Right.
And then also like individuals who may need donor eggs, donor embryos, donor sperm, surrogacy, that also falls under the category of how we define infertility.
Oh, very good. Okay. And so infertility, we do you just look at women, or is it women and men, or couples
Women,
together?
both, everyone, women, men, transgender men, trans women, same-sex couples, single individuals, so whole, really everyone.
Yeah,
Yeah.
right. And you have ways of helping pretty much everyone now.
We do.
Yeah,
Even the adolescents, the
yeah,
pediatric population, we see them as well.
yeah.
Um, Usually for more difficult situations. But yeah, we really have a full breadth of individuals that come to our
Wow.
clinic.
Yeah. How long did it take you to train for this specialty?
So it took some time. It was 4 years of undergraduate, 4 years of medical school, 4 years of residency, and then 3 years of fellowship. So all in all,
That's a
15. Is
journey.
that if I did the math right?
That's a
15
long
years.
journey.
Yeah,
Yeah,
yeah.
yeah. And then you come out of school and you're like a brand new doctor. And then
Yes, you're a
yeah,
brand new graduate,
yeah,
and that can be very overwhelming because now you're out in the world on your own,
yeah,
and it's a sharp learning curve, but a learning process. Really, we kind of all go through the entirety of our careers,
yes,
constantly learning, but
yeah.
it's good. Yeah.
And then, so tell us a little bit about the lifestyle factors that people, that maybe they're living through stress, or
hmm
maybe they smoke, or will that affect their fertility, like the way they live their lives?
Yeah, so there are certain lifestyle factors that will bring up with patients about what to work on at home. So, for example, smoking. We definitely recommend stopping smoking, whether it be cigarettes, vaping,
Mm.
e-cigarettes, really all of that. And smoking has been associated with losing eggs faster in women,
Oh,
and menopause can start earlier, as soon as 1 to 4 years earlier. So, we want those eggs if we're hoping for pregnancy.
yeah,
There's also an increased risk of miscarriage in women who smoke. For men, it can also decrease the amount of sperm and the motility of sperm. So we do also encourage men to stop smoking.
great.
Um, Alcohol is another one that we talk about. So in general, women who have two or more drinks a day are associated to or have been associated to have decreased fertility. And in men also, heavy alcohol use can lower sperm concentration, the motility. So we definitely recommend cutting back for men who are heavy users. Marijuana is another one we talk about. For marijuana in women, we recommend stopping it because there are studies associated with neurodevelopmental issues in the fetus, and if they're planning to be pregnant, that wouldn't be ideal.
Yeah,
And then for men, it can contribute to ejaculation problems, erectile dysfunction, and then sometimes decreased sperm count and motility in men who smoke marijuana. So that's another one we recommend cutting out.
yeah.
Caffeine is one that we get asked about a lot. For men, we really don't have much data, so
Okay.
there isn't like specific concrete evidence in men. For women, they say greater than 500 milligrams of caffeine is associated with decreased fertility, but that's about 5 cups a day, which is already quite a bit.
It's a lot. I
And
do know
it's a
people who
lot.
drink that much.
Yeah. And then in pregnancy, I mean, once a woman's pregnant, our criteria goes to 200 milligrams, keeping your caffeine intake under 200 milligrams a day. Above that's associated with miscarriages.
Right.
And then the other one we look at is body mass index. So of
Oh,
course
yeah.
we encourage healthy lifestyle, eating, eating at home, less processed food, foods that are rich in antioxidants, regular exercise. There are studies showing that obesity is associated with irregular ovulation in women,
Yes.
irregular menstrual cycles, also associated with increase in birth defects, increase in miscarriages, lower embryo quality. And then the flip side is very lean women, underweight women. That has also been associated with increased time to conceive. And so, it's really looking at like the nutrition, making sure we're getting enough calories. And sometimes we work with a nutritionist to help guide us if we're running into problems.
That's so interesting.
Yeah, yeah.
Yeah. Yeah. So what steps would you take in diagnosing? Do you
So whenever someone comes to us telling us that they've had trouble getting pregnant, there's a few different areas that we try to evaluate to get more information. With a woman, we check ovaries, so we look at the ovarian reserve. As we get older, we all lose eggs, and it's
yes.
to be expected. But we want to get a sense of kind of where are we at this stage, and so there are a couple ways you can assess ovarian reserve. One is by blood work, and there's three hormones that are commonly done: FSH, which is follicle stimulating hormone;
Mhm.
estradiol, which is estrogen; and anti-Mullerian hormone, or AMH. So those are the three blood tests that we'll do, and then at the same time, we'll also recommend doing an ultrasound, a vaginal ultrasound of the ovaries.
Yeah.
And the ultrasound will actually guide us because we get to see little follicles. Follicles contain eggs, a little sac-like structure, and a woman has thousands of follicles with eggs that we don't get to see. Those are microscopic, but every month a group of them, a cohort of them will appear, and those you see on ultrasound. So we count them and
Yes.
we see, how the numbers look. Is it high or low? If it's low, is it mildly low or moderately low? Um, so that's assessing the egg reserve, and then we also evaluate the fallopian tubes. The fallopian tubes are essentially where the egg and sperm find each other and fertilize. So we want to know that the tubes are open. And a commonly performed test is called hysterosalpingogram, or HSG for short. Um, but the test is done with by placing a catheter inside the uterus, and through the catheter, a liquid is injected, and that liquid will basically fill up the uterine cavity, go through the fallopian tubes, and if everything is open, that liquid will spill right out, and you can see that liquid on X-ray. So at the
Mm.
same time, X-ray photos show the passage of the fluid go through, so you know that the tubes are nice and clear. And what's
Right.
nice about this test, even though it's supposed to help diagnose any issues with the tubes, there is actually increased fertility afterwards.
Oh,
And so
yeah. Yeah.
I always tell people, if you're going to do the test and you want to be pregnant, go ahead and try after, because sometimes that's all it takes.
Wow. It's
Uh,
like cleaning out the
it's like
plumbing.
clean, yeah,
Yeah.
exactly.
That's so
Clearing out
great.
debris, mucus. A real blockage you won't fix, but like some of the times the debris and mucus get flushed through.
Oh, wouldn't it
Uh,
be great if that was all it was?
I
Yes. How
know, I
wonderful.
know. And then we also check the uterus. The uterus is
Yeah.
very important to us because that's the area where pregnancy occurs. And
Hmm.
and usually the evaluation of the uterus starts off with a simple vaginal ultrasound. So at the same time we look at the ovaries, we look at the uterus, and we look for fibroids, which are benign tumors of the uterus. We look to see if there's any abnormal contour or shape to the cavity, and if there's any suspicion, you can really evaluate the uterus more closely. And oftentimes we'll do a saline ultrasound, which is where you put a catheter in the uterus and fill it up with fluid, so saline salt water, and
Yeah.
you do an ultrasound and you kind of see, is there any anatomical issues? So sometimes people have a little growth like a polyp or a fibroid, and it shows up as whitish gray in the background of black, or scar tissue may show up if people have had procedures on their
Mhm.
uterus. So we'll do that, and then further take it further with a hysteroscopy and put a camera inside the uterus if we need to take anything out of the cavity and get it as normal as possible. So those are the common tests that we do in women. So really checking the egg reserve, checking the fallopian tube, see if they're open, and looking at the uterus to make sure we don't have any fibroids or
Right.
polyps of concern.
So that's kind
Uh,
of like looking at the physical structure of her
to-
body. Yeah,
Exactly. Now,
fabulous.
and then there's men, right? So we of course
Right.
want to examine them. So a commonly performed test is a semen analysis. So that checks the sperm, and there are a few numbers that we look at when we do a semen analysis. One is the volume of semen, and so we like to see that the volume is sufficient. Sometimes if it's very low, it could be due to just the uncomfortable nature of asking a man to produce for us, but
Yeah.
sometimes it can indicate an abnormality or a blockage. We also look at the concentration of the sperm, so like really how many millions of sperm are there per milliliter,
Yeah.
and we look at the motility, what percentage of them are moving, the morphology, like what percentage of them have a normal shape to them, and this gives us a more complete picture as to like what's going on the male aspect, and depending on what we find, sometimes further tests are needed.
And would you get that specimen at your office or at the lab, or does he bring it
Yeah.
from home?
So absolutely, there are a couple of ways of doing a semen analysis. One is to do it in our office. So in our Thousand Oaks office, we do have a lab, and we schedule men there Monday through Saturday, and they can produce a sample either on site. So there's a room that we have for them to use,
Yeah.
produce it, and just turn it into us. Alternatively, a lot of men prefer to do it at home, and that's totally fine. We give them a specimen container ahead of time, so they have that, and then you usually want to bring that sample in within 1 hour of
Within
producing
1 hour.
it.
I was just
Yeah,
going to ask
yeah.
how long,
Yeah, you
how
got one
long.
hour to bring it in just so that it stays close to the temperature, the core body temperature, and doesn't get
Right.
too cold.
And are there any like big breakthroughs in that part that's new or exciting to do with like sperm count or
I'll tell you, a lot of urologists will say this too, but we know so much more about women and fertility than we do about men and fertility. And that's the frustrating part, is because if we pick up an abnormality, there's definitely a checklist of things that we're thinking about and wanting to rule out. But it's not unusual that we go through that checklist. Everything seems to be fine, and we don't have an explanation
yeah.
of why the numbers might be lower. And that can be frustrating when we don't have an answer. But and I'll hear this a lot from the urologists, is just we just don't know as much about men and fertility than we do about
Yes, it's a
women.
shame,
Yeah.
isn't it? Because we,
Yeah.
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 So that's interesting, though, too.
Yeah.
And then tell me, what's the next step? You've looked at the physical.
Yes.
What's the next part that we
So
look at?
after the testing's done, we oftentimes will regroup in the office, and I'll meet with the patient and partner possibly, and kind of go through all the results, see what we have, what do things look like, and then we talk about different fertility treatment options. And there's a whole range of fertility treatment options, but ultimately what the group decision we come together in the office is really based on the individual or couple's preferences, what their test results are showing, what their goals are. I mean, are they looking to have one child, and they're good, and or do they want a big family? They may want three children or four children, and they want to plan ahead for baby number two, three, four. And so, kind of keeping all that in mind, we hone in on what might make the most sense for that individual in terms of fertility treatments.
Right. And then, so what are the treatments? How do you start?
So there's a whole range of treatments, going from like easy, simple to more advanced. And so I usually go through the full spectrum, and then we go from there. But the more simpler treatments are so actually all the treatments are operating under the premise that every egg is not going to give us a baby. Every egg is not a healthy egg. And that's to
Yeah.
be expected. As we get older, the quantity and quality of our eggs will decline. And even a 25-year-old, you would say, oh, well, that's great. That's a young age. But we know every egg of hers will not produce a child. But,
Yeah.
as we get older, the percentage of good, healthy eggs will drop. And so for fertility treatments, we'll say, okay, if every egg is not good, maybe this, like as far as the simpler treatments go, let's try to ovulate maybe one or two or three eggs. And this is commonly done with the medication. There's pills that are out there. There's one called Clomid or clomiphene citrate. There's another one called Femara or letrozole. And these are pills typically prescribed for 5 days. And the purpose of them is to induce growth of one, two, or three follicles. So each follicle has an egg. So ideally, like one, two, or three eggs may grow from them. And we do ultrasound monitoring so we can see, well, how is the response to the medication? All of these medications typically will start with a period. So we'll have a woman call us, we'll bring her in the first few days of her cycle, do an ultrasound, and then get her started on the medication. And then about a week later, they come back and we do a second ultrasound and we get to see what happened. And we're hoping to see one, two, or three follicles grow, and we measure them. And once they get to be pretty good size, then we can control when a woman ovulates. So at some point she will ovulate, but what we like to know is are you ovulating, so we know that the sperm is going in at the best time possible. And so
Yes.
there's an injection that we can offer women. We call it a trigger shot because it triggers ovulation. And so a woman can take it, and once she administers that injection, we'll know, okay, this is the optimal window for sperm to go in. And so at that point, she can decide if she wants to do intercourse with a partner. And if so, we'll tell them the good days for that. Or we can even take it a step further and do something called IUI or intrauterine insemination. And this is where we take a man's sperm. It could be her partner, it could be a sperm donor, but we would take the sperm, wash it, spin it, collect all the moving sperm and the dead sperm and debris, you leave those behind. And then we get the sample concentrated down. So it's just like half a milliliter of just like super concentrated sperm. And we'll put a really thin catheter inside a woman and then inject that sperm through it. And by doing that, you're taking that sperm past the vagina, past the cervix, top of the uterus, which is where the fallopian tubes are attached. And so by doing so, more of that sperm gets in, more sperm gets through the fallopian tubes, and hopefully finds that egg. So you're increasing our probability by hopefully having one, two, or three eggs in contact with more sperm.
That's
Um,
so great, isn't it? Yes.
it is, it is. So everything I've described is considered it can sound very overwhelming at times, but it's considered the more gentler, simpler type of treatments.
Like
Um,
first
and and
line. Yeah.
First line, yeah, and a
Yeah.
lot of times people will start there because if it works, great, we're done. And we kept it as simple as possible.
Yeah.
Um, and of course, our hope is always, we would love for things to be natural. I mean, I know I acknowledge that when people come to see us, it's not because they want to be there. It's the more natural method may have not worked at home, and they're having
Right.
to see us. And so now there are. Go ahead. Yes.
Well, I was just thinking for the women who might be listening or the couples that might be listening to us here. Um, so, so just to recap, um, they may not have to go the full IVF. They hear about IVF route,
Correct. Correct.
that there's a few steps and it might be the very start, the simple steps at the beginning that can help them achieve that pregnancy. So
Correct.
they shouldn't shy away from going to an infertility doctor with the fear of
Of IVF. Yes,
IVF.
IVF can be very daunting and it's not for everyone. And a lot of times people will start off with simpler treatments, and if it doesn't work, maybe then consider IVF. And some people go straight to IVF and some people never want to do IVF, and that's okay. The right decision is really what's right for the individual or the couple. I mean, it's you see so many people and it's not going to be the same answer for everyone.
Right. Amy, tell me, what is IVF?
IVF stands for in vitro fertilization. And this is a process where eggs are fertilized outside of the body. So meaning not in the fallopian tubes, but rather in a laboratory. And you create embryos in a laboratory, grow embryos in a laboratory, and then eventually put an embryo in the uterus. Now, that's a very simplified approach to describing IVF, but essentially it involves a woman taking hormone injections. So typically women would be on hormone injections for about 10 days. And the purpose of the injections is to grow follicles. So not just one, but maybe more. And more is based on her reserve. And so in some women, it might mean five. In some women, it might mean 15 or 20. But we grow them over the next 10 days and we monitor those women with ultrasounds, blood work, watch those follicles grow. And then around the 10th day, we say, okay, we're done. 2 days later, we do a procedure under anesthesia. And this procedure is called the egg retrieval. And essentially, it's about a 15-minute procedure. So it's not very long. And a woman is put to sleep with intravenous or IV anesthesia. So she's still breathing all by herself, but she's asleep. And once she's asleep, we put an ultrasound in the vagina and a needle. And that needle will poke through the vagina into that ovary, into the follicles. And at this point, there are multiple follicles that have grown, so a needle enters one of them, suctions out all the fluid, and with it should come an egg. And if there are 10 follicles that grew, we're trying to hopefully get 10 eggs from a woman. And so whatever we've suctioned out, all that fluid and eggs, all of that goes to the laboratory. And in the lab, so our lab is actually connected to our operating room. We have a window where we pass the vials of fluid and eggs to the lab. And in the lab, there's an embryologist under the microscope, and they're counting the number of eggs we got. So they're looking at everything that's been suctioned, and they're like, okay, we have one egg, two eggs. They're counting in real time.
Wow.
And so then once a woman is awake, we tell them, hey, we have X amount of eggs. Um, Now, at that point, the work really transfers over to the laboratory, and so they're going to take those eggs and they're going to fertilize them with the sperm. So typically that day, we also have a sperm sample provided, and in the lab, the next day they look to see which of those eggs fertilize. And so at that point, we call them embryos, and those embryos are grown in the lab for about 5, 6, 7 days. And we're looking to see which of those made it into a blastocyst. A blastocyst is an embryo that's approximately 200 cells big. And we know all of these eggs were not destined to work for us. So there is a bit of a drop off. And I usually prepare individuals to know that, hey, know that we're not, our end result will always be lower, but there's a reason we may grow 15 eggs. It's not because we were planning for 15 children, but we know sometimes it can take that to find hopefully a good one or a few good embryos. And so on day 5, 6, and 7, after the egg retrieval, the lab will see, well, which embryos do we have? And whatever we have, all of that gets frozen and kept for the individual or the couple to use at a later time whenever they're ready. Now, there's an extra step that can be done, which is becoming more and more popular and more routine, and it's called pre-implantation genetic testing,
Right.
PGT.
That was
And
one of my questions.
yeah,
Yay.
so it's a test where you can biopsy an embryo. And you can grab a few cells from that embryo and send it out. And you're looking to see if there's any chromosomal abnormalities. Now, chromosomes contain our DNA, and we all should have 23 pairs of chromosomes. So 46 chromosomes in total, half from the maternal side, half from the paternal side. And so um, what can sometimes happen is some of these embryos will have an abnormal amount of chromosomes. So they may have an extra chromosome. So instead of 46 chromosomes, they have 47 chromosomes. Or they may have a deletion of a chromosome. So maybe 45 chromosomes instead of 46. Now, one chromosome can contain about 1,000 genes. And so if you're missing or gaining extra chromosome, you're essentially missing or duplicate or I guess triplicating 1,000 genes. So all those extra genes, a lot of times they can be incompatible with life. And so if you know an embryo is genetically abnormal, then you would know not to put that in, and then focus really on which ones came back normal.
Now,
Um,
those genetics would have been the same whether they had conceived naturally or in the lab. right?
Correct, correct.
Yeah,
So yeah, and I always tell people, if you're trying to conceive at home and you're doing everything you can, you're tracking your ovulation, you're having intercourse at the optimal time, you feel like you've done it all. There are probably scenarios where an egg did fertilize, it did become an embryo, but that embryo was not a healthy embryo and never implanted, and the menstrual cycle started, 2 weeks later. So
yeah,
so these abnormal embryos actually form all the time,
right.
and it can be pure errors that occur during fertilization, but a lot of times it can stem from egg quality, and then sometimes it can stem from sperm quality, and sometimes it can stem from both. But as we get older, we know the quality of eggs go down and these genetic abnormalities go up, and that's actually the main reason we have
Yeah.
more infertility as we get older and more miscarriages, is that we're forming more of these abnormal embryos.
Wow, interesting. So then what's the next step now? Where are we in our story?
So, okay, so if so we're at the stage of, we have the embryos, maybe we biopsy them for PGT, the pre-implantation genetic testing. We have our embryos frozen. About 2 weeks later, we get those results back. And so hopefully we have at least one good embryo in there. And if so, we're planning on putting that embryo in. So now we're switching gears to something called an embryo transfer. And an embryo transfer essentially involves getting a woman's uterus ready. And there are different ways of accomplishing this. The traditional or most common approach is doing something called a programmed frozen embryo transfer, which is where she takes estrogen to help thicken the uterine lining. And it takes about 2 weeks to accomplish that. And during that time, we're doing ultrasounds so we can watch the uterine lining, that area of implantation. We watch that area thicken. And assuming it looks good, we'll say, okay, now let's start progesterone. And the progesterone comes as vaginal progesterone. It also comes as intramuscular progesterone, which is injections in the buttocks, which of course would be um, taught to the woman before starting. But the idea is progesterone's important for that uterine lining to get ready to these microscopic changes that will occur that help that uterine lining receive that embryo for implantation. And so typically a menstrual cycle to an embryo transfer can be about 3 weeks, and of preparations with the hormones, and then around that time we're putting it in. And putting an embryo in is actually much simpler than the egg retrieval. And I always tell women that don't think about the egg retrieval. That sometimes was the hardest and most intense part. But
Yeah,
an embryo transfer essentially involves putting a very thin, soft catheter in the uterus, and it's so thin and soft that oftentimes women don't even feel it.
right.
They're usually awake. Their partners can be in the room with them. Some we offer Valiums. Sometimes women love to take it to like help them feel more relaxed, and that's great too. But once the catheter goes in the uterus, we deposit the embryo and we do an ultrasound at the exact same time. And so by doing an ultrasound on the belly, you can see that catheter go in, and then you inject, and that embryo gets placed inside the uterine cavity. And then 9 days later, approximately, we find out if it worked. Um,
It's so amazing. I visualize a beautiful garden in there that you're like you've gotten it all ready and it's just perfect, and in comes this amazing little being. Um, so fabulous. Um, so that is the part where then you wait and see has it
we wait
worked.
and see. We wait and see. Yes, exactly.
And how long then will it take before they know if she's pregnant?
So most people will do a pregnancy test about 8 or 9 days after the embryo has, or 8, 9 or 10 days after the embryo has been placed, and then at that point, if the blood test comes back positive, and we see, okay, yes, we are pregnant, we'll repeat the level a few days later to see if it's rising well. So at that stage, it's too early to see an embryo on ultrasound, and so our first way of knowing we're off to a good start is to repeat the blood test and see if the the levels rise. And typically the HCG will double about every 48 to 72 hours. So seeing that rise gives us a little bit more peace of mind that, okay, we are off to a good start. And then about 2 weeks after that, we'll do an ultrasound. And at that point, we're hoping to see a pregnancy sac or a gestational sac in the uterus. We're hoping to see a yolk sac. We're hoping to see an embryo. And we might just be at the stages of hopefully seeing a heartbeat, a little flicker on there. And then, if, assuming all looks good at that point, we'll follow them with ultrasound and then eventually graduate them to their OB/GYN, their midwife, to start their prenatal care and hopefully keep us posted on how things progress.
Yes, and I mean that's when we see them, and
Yes.
they're usually so excited, and a lot of them are usually very anxious and
Oh,
nervous,
yes.
and almost afraid to like start to bond with this baby. But we eventually do the anatomy scan, and they're like, so happy then to see their little being. Yeah, that's such a great journey, and it's such a hard journey for some women. So emotional for people, isn't it? How do you support them emotionally throughout all of this?
So actually love talking about that because most people by the time they come and see us, there's already history there. And so kind of like what you were saying, when they're pregnant, it's sometimes hard to accept that, oh, this is good. Things are actually progressing well, because you can't help but remember some of the
Yeah,
history, and you can't help but feel guarded. The last thing that someone wants is to feel devastated, things didn't work out. And so there's definitely some guarding initially, and sometimes it's hard to believe it's real. But we see it a lot, and it's something that I oftentimes will talk with individuals about. I mean, 1 in 6 couples have trouble conceiving, and that's not a tiny number. It's actually quite common, and you see the toll it can take on individuals, on couples. I mean, you're essentially feeling like your basic desire to have a child may be unattainable, and that is, going back like hundreds of years. I mean, having children was just that was the basic part of life, and to say that that may not be happening can be extremely anxiety provoking. It can
yeah,
trigger depression. We see people feel shame, feel guilt. We see that all the time. And then the kind of the stress within a relationship too, and there can be that shifting of blame, and it's not, we don't want to ever say that it's so and so's fault that they're not pregnant, because really it's a lot of this is beyond our control, and it's just an
yeah,
unfortunate situation that's occurred. And people start to complain that sex is no longer pleasurable. What once used to
yeah,
be fun and spontaneous has now become a chore. And so we
yeah,
definitely see that toll it takes on the individual or couples. And there are resources thankfully out there to help. And so I mean, hopefully we as physicians, we as providers are one resource, because we're with them in this journey, and we're determined to see them through it. But there's organizations out there. So our American Society of Reproductive Medicine, they've created a website called reproductivefacts.org, and it has a lot of like information, fact sheets for people to look at, which I think sometimes just not having the answers and not knowing can also be anxiety provoking. So I always encourage people to ask questions. Don't get the overwhelming sensation just build up. Like, if there's something you need clarification, always reach out. We as physicians have a plethora of information we're trying to share, and
yeah,
our nurses are absolutely amazing. They're constantly on the phone. I can hear them talking to the patients, explaining what the next step is, and it just kind of brings a sense of peace of mind. But there's also therapists, there's also psychologists, sometimes psychiatrists. Some people need to be on an antidepressant or a medication for anxiety, and that's okay.
yeah.
That's absolutely okay. We have to do what will get us through
Mm,
this, and it's okay to ask for help. And I think
Yeah.
that's important. There's a great website, resolve.org. So that's also like our like a national infertility support organization. They have resources on there, tons of resources on there. People find support groups, and you can find support groups that are specific to you. And so, for example, I have a single woman who's African American using a sperm donor, and she found a support group of other single women who are African American also using sperm donor. I think that's amazing. So,
It's
she really
great.
could connect with others out there
Yeah.
who are going through the exact same thing. But lots of support groups are available, and but talking about it, I think, is helpful. And
Right.
one thing that I think that is that I've noticed a shift in over the years is infertility is not the taboo it was once was.
Yeah.
And I think this is with social media, a lot more people are talking about it. You're hearing so many others struggle with this, and now you don't feel alone. And I think
Yeah.
that also helps.
Right. Um, and what about same-sex couples? I'm sure you come across that a lot. I have some friends right now trying to um, have a baby, and they've tried at-home insemination
Yes.
numerous times. I
Yes.
think this next few days they're going to try once more, and if it doesn't work, I'm going to send them to you.
You got it. No, so we see a ton of same-sex couples. And so for our lesbian patients, we're talking about sperm donor, and sometimes they're using a sperm bank. Sometimes they're using a directed donor, maybe somebody they know that they want to use. We talk about getting some testing done for them, especially if they've already done home inseminations and it hasn't worked. It might be nice to know, like, are there any potential obstacles that we should be aware of? And so that goes back to some of the testing that we offer, like checking the egg reserve, doing an ultrasound, sometimes checking the fallopian tubes, and then we talk about options such as IUI. So essentially, taking that sperm further in. So when they're doing home inseminations, the sperm is deposited in the vagina, but by doing an intrauterine insemination in the office, we're taking that sperm past that vagina all the way to the top of the uterus. And then in some women, we'll even try the medications to maybe ovulate a couple eggs, especially if someone might be on the older side or have already tried a bunch at home. We might say, well, do we want to try to ovulate a couple eggs, knowing every egg may not work out for us and maybe increase our
Yeah.
odds. And then IVF is obviously still there. And with IVF, you can get creative. We do reciprocal IVF. So essentially making embryos from one woman's eggs, but implanting it into the other woman's uterus. So
Yeah.
that way they both feel like they're part of this process, which is kind of
Right.
cool to be able to do.
Yes.
Um, and then we also have gay men as well who are also looking to have children. And so for them, we'll oftentimes talk about finding an egg donor. Um, Finding a surrogate, and essentially using egg donor to fertilize with sperm from either male partner or both, and sometimes we
Yeah.
create embryos from both men, and then hopefully finding that surrogate to put that
Yeah.
embryo in and have that baby.
It's so exciting because it can bring so much joy to people who are like longing for a family. Um,
Absolutely.
yeah, I come across it. I see the work that you do, and it's just like amazing to see the joy on their faces to place that baby up there on their chest, and their life all starts together. That it wouldn't have happened without people like you, and we
Mhm.
really, really respect the work that you do.
Thank
Um,
you.
Now, there is, of course, the problem with insurance and
Yes.
costs and all of
Mhm.
that. So it's hard for some people to get this care. Tell me a little bit about the costs.
Yeah, so IVF, of course, is not a cheap treatment, and most people in California do not have insurance coverage. So the majority who are doing IVF still pay out of pocket.
Yeah,
Um, Roughly an IVF cycle, you factor in the actual treatment plus the medications plus doing PGT and testing your embryos and then putting that embryo in. I mean, all in all, you might be spending around 25,000. And then there's yearly storage fees. So every year there's a fee to keep those embryos stored. And so that's between 600 and change. I don't quote me on the exact number, but that's the billing department would of course go through all this in detail. And but it's not a cheap treatment. And it can be a huge financial burden for some individuals. There are grants available, and so that website resolve.org, they do put out grants on there that can help individuals. You apply for them, and sometimes people qualify and they get a large chunk or all of it covered, which would be amazing. Um, there's more and more patients, I think since 2019, who've had insurance coverage for IVF. So I will say, even though majority don't have coverage, it's getting better. And a lot of these folks are people who work in tech companies. So the tech companies have been very uh, have had the forefront in
Yeah,
offering these insurance plans that do cover IVF and cover fertility treatments. And so it's getting better. And there's a bill that you may have heard of, the SB 729.
yeah,
So that's the California state bill that's supposed to mandate employers provide IVF coverage, and in the state of California, which would be amazing and make
yeah,
these treatment options more attainable for so many. The problem with that is, the date for it to be effective got pushed back. So the original date was July of 2025, which now has been pushed back to January of 2026. Things are still up in the air, and
yeah,
and we know eventually we will get there, but it's hard to know when people are going to be able to have
yeah,
that Senate bill in effect. And there's already one bill in effect, SB 600, which actually does cover egg freezing in certain populations, especially where infertility may arise. So your classic individual is someone who may have recently been diagnosed with cancer and they're going to be starting chemotherapy and they may want to freeze their eggs beforehand. So a lot
yeah.
of insurances will now cover that because there was a medical indication to freeze eggs ahead of time. Yeah.
Great. And
Yeah.
would they provide that opportunity for somebody who's like wants to freeze their eggs because of their age? Like if they're
Unfortunately
over,
not,
no,
because it's
yeah,
still like which is the most common reason why people freeze their eggs
right,
is they know that
yeah,
fertility goes down as we get older, and they may have not met the right person, the partner they want to spend their life with, but
yeah,
they want to freeze their eggs now. And unfortunately, age at this time is not considered a medical necessity, and so it
yeah.
is considered elective for most. And so if you don't have egg freezing coverage, it's usually out of pocket.
That's a pity, isn't it?
Yeah,
Yeah.
yeah.
I know some women who like that. They're just not ready, but they
Hmm.
definitely want a baby in the future. And that's probably expensive too to freeze the eggs. Do you deal with that part? Do you?
So we do tons of egg freezing. We have lots of individuals come through who do want to freeze their eggs. We have an excellent billing department that will meet with anyone who is considering this, and they will give them a breakdown of what to
Yeah,
expect. So there aren't surprises, and this is something that I would say is a huge plus with our practice is the transparency. So we don't like hidden costs. We just want you to know what it is upfront, so that the whole process can be stressful. We don't want
mhm,
this to be another source of stress. And so there's a wonderful billing department that will break it down for the individual. It's not as expensive as IVF since we're not doing everything that you would do for IVF, but yeah, it can run about 7,000
yeah.
approximately plus medications.
And then tell us a little bit about the ethical issues that you come across. I know some people have like religious um,
Mhm.
ideal that they feel like this is going against their religion,
Mhm.
and yet they really want to have a child, and you know you can help them. And do you ever come across anything like that?
Absolutely. We see it all the time. So, in some religious practices, it's not acceptable to have sperm taken out of the body and fertilize an egg outside the body. And
Yeah.
so I have some couples who are actually not okay even with IUI because that's
Mm,
essentially taking the sperm externally and putting it in. Um, and so I think a lot of it is just kind of having that open lines of communication, like what is considered acceptable, what can we do that would be acceptable for you and also give you the best chance. For IVF, I have plenty of couples who are not okay discarding extra embryos. So some of our women make tons of eggs. They may be young, or they may have polycystic ovary syndrome, and they just happen to have so many eggs, and they worry about creating all an excess of embryos and maybe only wanting two children and having extra embryos that are frozen, and then eventually being forced to make that decision: do we discard them or not? And so if it's ever a concern, we can always tweak the plan. So some individuals will just fertilize a few eggs, and then the remainder of the eggs will just keep frozen, unfertilized, so that way we don't create that surplus of embryos. And so there's definitely tweaks that we can do. We just kind of, as long as we know, we're happy to work with you and figure out what makes the most sense.
Do you ever come across an embryo, um, like where the patient would donate their embryo?
Yes, yes. So we see that in patients who may be done having children, like they had extra embryos, and they say, "Well, I'm done, but I'd love to donate these embryos to someone else who might be in need." So we see that, and we do that. We have our embryo donation program at our practice. We also have we have some patients. I had one, unfortunately, she and her now ex-husband were divorced, and they had created all these embryos and decided not to use them, so they donated them. But yes, we definitely have it, and I see people sometimes
Yeah,
interested in that. And sometimes
yeah,
it's our single women, who may be older and maybe needing an egg donor, and they already need a sperm donor, and they might say, well, if I'm going to get an egg donor and a sperm donor, why not get a donated embryo
yeah.
instead? And so we definitely see it, and we definitely do it.
I have a
Yeah.
friend
Yeah.
who had, I think she has like four children.
Uh-huh.
She's in her early 40s, and she didn't want these embryos to be wasted. They weren't her embryos, but she managed to get one, and now
Mm.
she's a new baby in her early
Oh,
40s. But she did that for a religious reason. So that's like the other side of that religious
absolutely.
coin. So very interesting. So I just recently saw a report where in China they've developed a robot where they can grow a fetus from an embryo in the robot where they don't need a uterus at all. Have you
That is,
seen that?
I have not.
It's,
I don't know when it's something we would do in the US, but
yeah,
it's crazy where
that's pretty
science
wild.
is headed.
Yeah, yeah.
Yeah.
It's probably just at the start to. I know. I was like, what? That's wild. It makes me feel very lucky to be this old because as a young midwife. Actually, as a student midwife back in Ireland many years ago, I remember a scenario where I was with the OB in the office, and he said to me, "Here, Sally, take this little cup," and it was like a urine specimen cup, and he said, "Go out to that man in that white van and ask him for a specimen of sperm." And I was like, okay. I just thought like I have to just go do it. And I went out, and he was what we call the travelers, and his wife was in the clinic with us, and she hadn't been able to conceive for like 6 months, and he was like, "There's
Mhm.
something wrong with her, fix her." um, and so I asked him and tapped on the window, and I held my little specimen up, and I said, "The doctor wants a specimen." And he says, "A specimen of what?" And I says, "A specimen of sperm." And so he freaked out, started shouting and roaring.
Oh
And
no.
it was a joke that the doctor was actually playing on me because he knew that this man was not going to, take responsibility. Uh, so I turned to go back in, like totally embarrassed and freaked out. And there was the doctor and all the nurses at the window laughing because
Oh no.
they, but it's kind of like rite of passage, the things they
It
used to
is.
do at home. But
Yeah.
to come from that scenario so many
Mhm.
years ago and then to this scenario, to be able to talk to you and the advances that we've made, it's just so exciting.
It is,
I
and
mean,
it's humbling at the same time. It's amazing, but like crazy how far we've come over the
yeah,
years.
so wild. I mean, I've delivered a lot of IVF babies throughout the
Mhm.
years, and all births are exciting, and
Yeah.
to welcome this new little person. Um, but there's something so exciting seeing the IVF parents meet their baby. It's
Hmm.
so emotional, so beautiful.
It
The
is.
work you do is important, and it's so exciting. And like you say, there's breakthroughs all the time,
All the
and
time.
you're right there on the
Yeah.
edge of the cliff. It's
Yeah.
great. Um, any resources or websites that you'd like to tell us
So yeah,
about?
so the reproductivefacts.org, resolve.org, those are great ones to start with. I'm trying to think of what else off the top of my head. Um, I think those are good starting points for patients to start looking at, and come to us and ask us, whatever we can do to help, we're happy to help with too.
Yes. So I have so much more now I can share with my patients. Often they come in, and like recently I had a patient, she was young, only 6 months, trying to get pregnant and crying, crying. It wasn't happening, and why wasn't it happening? Is she
Mhm.
infertile? And she's like 28 years old and
No.
healthy and strong. And um, like for her, I like you say, I said give it the 12 months.
Hmm.
But what else could I tell her? How else could I help a young woman like that?
Sure. So, I mean, it kind of delves, you want to delve a little bit more in their history. Are her cycles pretty regular? Things that she could do at home, ovulation prediction kits, if she hasn't explored that. The ovulation prediction kits are give you a lot more insight into the cycle and kind of give you a sense of like when you might be ovulating. And I always tell people there's so many different options for ovulation kits out on the market these days. I'm more traditional, say stick with something simple. It can get very overwhelming. There's a lot of fancier ones out there, and if it's something that sparks your interest, go for it, but you don't need to. The simple ones are perfectly fine. And the idea is you're testing the urine and you're trying to pick up a hormone called LH, which normally is low, but about 24 to 36 hours before you're ovulating, you'll detect a rise in LH, and that's when your test will turn positive. And so, in theory, if today the test turned positive, we know that we're ovulating the next day or two. But that's helpful because then okay, well these next few days are important for intercourse, and the highest probability of intercourse achieving a pregnancy is when sex occurs the day of ovulation, the day before ovulation, and 2 days before ovulation. That 3-day window is like the optimal time. And
Say it
so,
again. Say it
yeah.
again for the girl in the back.
Yeah. So the highest probability of conception during intercourse is when intercourse occurs the day of ovulation, the day before ovulation, and 2 days before ovulation. So the ovulation tests are helpful because it gives you that 1 or 2 day head start as to like, okay, you're ovulating the next day or two. So if positive ovulation test occurred today, then the next day or two you're ovulating. Now is the time to start, and you can have sex today, tomorrow, and the next day, and those would be the perfect 3 days of your interval. Sperm live inside for up to 5 days. Some people say maybe even a little bit longer, like 6 days. But once the egg comes out, it only has 12 to 24 hours to fertilize, and so the idea is you don't want to miss that 12 to 24-hour window, and so really the sperm should be waiting for that egg. And so that's why you really want to start having sex before all the way up to the ovulation day.
Great. And then, is there an age or a time when people should stop trying to get pregnant? Like we sometimes have women
Yeah.
into their late 40s, like still with that longing and trying. Is there a time
Yeah.
when they should
I mean, the
stop?
probability of conception using a woman's own eggs, like at the age of 45, the likelihood of, even if you're doing IVF, for example, and you're using your own eggs for IVF, the likelihood of having a child is roughly about 1%. So it can certainly happen, but um, you're going into it saying 99% it won't, and that's not a great
Yeah.
statistic to give somebody. And so, the egg quantity and egg quality will decline over the years, but in our 40s things change much more rapidly. And so, if you're in your 40s and you're starting this process, it might be worthwhile, even if you haven't had the 6 months of unprotected sex to qualify for that infertility label. Sometimes it's good to proactively see a reproductive endocrinologist and say, okay, well, these are my plans. I know I'm in my 40s. What do we need to do? And making a timeline, a game plan of like what would be best for these next few months to help increase your chances of getting pregnant. But 45 is, I would say, the age. I mean, now there's ways to get around it. Of course, we can use an egg donor at 45, and
Yeah.
that we do all the time, as long as a woman's comfortable with that. But there are ways to get around it so that we can still carry a pregnancy and have a baby
Yeah.
in our late 40s.
So amazing.
Yeah.
And what about surrogacy? Anything to share about that wonderful?
Surrogacy.
Yeah.
So, women will turn to surrogacy for a variety of reasons. The most common reason is they oftentimes they've already tried with their own uterus, and there's different forms of pathology in the uterus
Yeah.
that's prohibiting them from successfully having that pregnancy. And surrogacy can be a bit more complicated because you're essentially trying to find somebody who's going to carry your embryo and your fetus, like all throughout, and so it takes time to find that individual, find somebody that you feel like you can trust. I almost say it's kind of like dating, like you're getting to know them, because
Yeah.
and you want to feel comfortable with them. But eventually, hopefully, if you need a surrogate, you find that individual, and we help you with this, of course. And there's so many
Yeah.
agencies out there as well, that have recruited surrogates. But once you find that surrogate, of course, there's testing that needs to be done, to make sure her uterus is okay and there aren't any red flags on her end as well. And then there's, of course, the not so fun part, which is like having the legal aspect, which is very important to outline like what the agreement is. I mean, the goal is to
Yeah.
minimize any difficult situations down the road. So, there's a lot of prep work involved, but once all that's tucked away, we're moving forward with an embryo transfer, and it can be an amazing process and have
Yeah.
more people involved in it. And
Yeah.
it
Yeah.
feels like a party to
I
have
think
so
the
many people there. Yeah,
surrogates
yeah,
are such
yeah.
a gift. They're
They're a
so
gift.
great. I
It's
love it.
truly a gift for someone to
Yeah.
offer that with their body. Yeah.
Amy, do you remember the very first time a woman came back and was pregnant that you had helped? Do you remember that first?
Oh gosh.
Or do you
Oh, that's a
remember
tough one.
any in particular that really made you feel like I'm in the right job? This is where I should be.
I mean, we get people visit all the time, and it's so wonderful to see that baby that once was
Yeah.
a ball of cells. It's so heartwarming to like be able to see them again. And I always tell people, like, when they graduate from us, it's very bittersweet,
Yeah.
because we're sad to say bye, but so happy that they're leaving us for something so good.
Yeah.
And I always say keep in touch. Even high school graduation, I still like updates, although I've been in practice for 10 years, so we haven't hit high school graduation for any of them yet. But yeah, no, so many patients come to mind. I mean, I'll tell you one of my oldest patients, and not oldest by age, but oldest from when I first started practicing. Um, we had done an IVF cycle, it didn't work, and then I hadn't seen her for a very long time, and I had switched centers, and she found me years later, and we restarted IVF, and it took so many cycles, and eventually we got our token embryo
Yeah.
that worked, that stuck, that grew.
Yeah.
Um and 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 I remember we were talking, she was like, well, Dr. Dacey, if this had worked that first time, we would have had a 7-year-old by now. And I was like, yeah. But she had her baby, and it just makes me so happy. They're such amazing people, and I knew they would be amazing parents, and
Yeah,
to actually see it happen for them, and it took so much for them to get there, but it happened. And I
yeah,
love these stories.
yeah,
They never gave up and
yeah,
pushed through.
yeah. So I'm sure you see a lot of sadness in your job.
Hmm. Hmm.
Yeah.
We
Um,
do. We do.
and but perhaps that's a driving force.
It is. It's one of the toughest parts of our jobs is the sadness. We're
Yeah.
in there with the patient going through this. I mean, really, we're determined to see this happen and to see that success. So when it doesn't happen, it's devastating all around. And I mean, that's a time where, I'll take a step back and say, okay, let's regroup. And sometimes people need time. They need time to heal. They just need time away, and that's okay. And when they're ready, I'm here. Um, but but I always want to regroup and say, okay, from a scientific standpoint, so we talk about, the science behind it, what may have not worked, what our potential obstacles are, what we can do to moving forward. And then also from the emotional aspect of like, how are you doing? What can I help you through this process,
Yeah.
to make it a little bit easier for you? But it's truly devastating. That I think for any new graduate, that takes time. I
Yeah.
don't think we'll ever get used to it, but
Yeah.
it takes time to realize it's part of the process, unfortunately, for
Yeah.
some.
But then there's the success
The success
stories.
makes it so much better.
Yeah. Yeah.
Yeah.
Yeah. Wow. What a great chat we've had. And I was a big fan before we started this podcast, and I'm even more of a fan
uh,
now. And I hope to find lots of women that need your help. I'm going to send them your way. I'm going to attach your contact info to this if it's
Thank you.
okay.
Of
Um,
course.
yeah. And is there anything else you'd like to add, Amy? Anything else we should have spoke about?
Speak up for yourself. For every individual out there who may be thinking about fertility, just speak up. Like whatever we can do, ask questions, be heard. You're important, and we want to take everything into consideration moving forward. Whatever your values are, your goals, everything. So be an advocate for yourself.
Well, I am going to leave the last word with Dr. Amy Dhesi. That was perfect. Thank you so much for joining us today. And
Thank you for having me.
thank you at home if you're listening to this. Um, thank you for listening to the Bleedin' Truth, and we'll see you next time. Thanks a million.
Bye.
So thanks again for listening. We really appreciate it. And if you like what we're doing, give us a bit of a review on Apple. That would help us so much. And if you come across a subscribe button, press the subscribe button. It doesn't cost you anything.